Good morning, we are from PBL 15. Today we'll be presenting a case of Mr. C, a 60-year-old man with a 10-year history of type 2 diabetes mellitus. He has defaulted follow-up and has been self-medicating with metformin, 1000 milligrams taken twice daily. On assessment, his body mass index is 20 kilograms per meter squared, which is considered low. His blood pressure is 150 over 90 millimeters of mercury. His glycated hemoglobin or HbA1c is 8.2%, indicating suboptimal glycemic control. His serum creatine is elevated at 156 micromoles per liter. His estimated glomerular filtration rate or EGFR is 40 millimeters per minute, consistent with reduced kidney function. Additionally, his urine albumin to creatine ratio or ACR is 203 milligrams per millimole, indicating significant albuminuria. Overall, these findings are consistent with poorly controlled diabetes mellitus complicated by stage 3B chronic kidney disease with significant albuminuria.
So for the patient's glycemic management, we first suggest to reduce the metformin dosage to a maximum of 1000 milligrams daily, considering that his EGFR is 40, and then add on an SGLT2 inhibitor such as dapagliflozin. And if the glycemic target is still not achieved, consider to add on GLP-1 receptor agonist. And finally, if the control is still inadequate or if there's any symptomatic hyperglycemia, initiation of the insulin therapy is recommended.
The rationale is based on CKD-specific recommendations. Metformin remains first line but must be dose reduced when EGFR is 30 to 44 to reduce the risk of lactic acidosis. SGLT2 inhibitors are strongly recommended as well in patients with diabetes and CKD because they slow kidney disease progression and reduce cardiovascular risk, and can be used when EGFR is above 20 to 30. Importantly, their benefit goes beyond glucose lowering.
If the HbA1c remains above target, then a GLP-1 receptor agonist will be preferred. This is because it provides cardiovascular benefits and additional glucose lowering without increasing the risk of hypoglycemia. Insulin may be needed in later stages, especially in patients with long-standing diabetes and beta cell failure. We will also avoid sulfonylureas due to increased risk of hypoglycemia in CKD cases.
Beyond glycemic control, several key issues must be addressed. First is blood pressure control. He should be started on ACE inhibitors or ARBs due to albuminuria. And second is initiate statin therapy for cardiovascular risk reduction. And the third one is to provide lifestyle counseling, including diet, smoking cessation, and also adherence. And the fourth one is regular monitoring of his renal function, HbA1c, and also electrolytes. And lastly is to screen for complications such as retinopathy and also neuropathy.
In conclusion, Mr. C requires a multifactorial approach, which is to optimize glucose-lowering therapy with dose adjustment for metformin as well as SGLT2 inhibitors. Other than that, Mr. C also requires patient education as well as close follow-up and aggressive cardiovascular and renal protection. Early intervention is crucial to reduce the risk of chronic kidney disease progression and reduce morbidity as well as mortality.